patients are concerned about the sterilization of equipment.
Yes.
And how does that happen in?
Well, the standard for cleaning our endoscopes is high-level disinfection. We go one above that, and we do actually sterilize the scopes. We use System 1 processors, and the parasitic acid actually sterilizes the endoscopes. So just to, you know, go that extra step for the safety of the patients and to put them at, you know, some peace of mind to know that, you know, we've gone that extra step to make sure that they aren't going to catch anything, you know, there's no cross-contamination. And in the 13 years that Dr. Muthuswamy has had the center, we've never, ever had.
Have you ever heard of complaints about infections? No. I mean, like anywhere in the field, does that happen?
Oh, yes.
Oh, it does?
It happens.
Yes, it's happened. It doesn't happen that often, but it does happen. We also do performance improvement and quality assurance tests to make sure that the employees are doing everything the way they're supposed to do it the way the policies are written, to make sure that things are sterilized, the biological monitoring is completed and documented the way it should be. Our center is fully accredited through the Joint Commission, and their standards incorporate the standards of the state and the federal government for Medicare purposes, so that, you know, we have to stay up to those standards to make sure that we can maintain our accreditation, and we take it very seriously.
Doctor, one of the things we're talking about at the break that has hit the news over the last year and a half is a virtual colonoscopy.
Yeah.
Now, that's not invasive like a colonoscopy.
You're absolutely right.
Is it just as good or no?
It is actually. It's done by a CAT scan, and what they do, the CAT scan slices so thin so you can see if you're going through the colon without putting your instrument. It's a radiation, you know, the radiology one. Preparation is the same. You have to prepare yourself like a colonoscopy.
So you still have to prepare yourself the same way.
Yeah. Only thing is they don't give a sedation. It's good and bad. Good is they're not giving a sedation. Bad is they have to put some air to inflate the colon to see very well. So people might feel more symptom than colonoscopy because they're not sedated. And the findings are almost equal, like what we are doing virtual, the real colonoscopy.
But if you find a polyp in a virtual colonoscopy, you can't clip it while you're there.
That's the problem. So then they had to go through the procedure what we are doing. But if it comes normal, at least they don't have to go through. But if it comes abnormal, they had to go through the procedure. But the problem with the virtual colonoscopy is, if I do a colonoscopy and if it's normal, we tell them come back in 10 years. Whereas virtual colonoscopy, we don't know when they have to come back for a repeat checkup. Nobody knows yet whether they have to come back in 3 years, 5 years. And also there's some radiations involved because of CAT scan. So on a long run, 10, 20 years duration, we don't know what the radiation effect will be.
I don't want to confuse anybody. You said 10 years if it's normal.
If you
have a family history, it's still quicker than that.
Correct, no. But if you go to a virtual colonoscopy, if it comes normal, we don't know when the patient has to come back for another checkup because they're not as accurate as a colonoscopy. So that's what the problem is. So we have to come in 5 years, 3 years, we don't know at this point. But the current recommendation is, if you're unable to go through colonoscopy because your heart condition or medical condition, or by chance we can go all the way to the cecum, then we give an option of going for X-ray. That's a virtual colonoscopy. So it still has some role.
Many Americans, and we were talking about the break about eating spare ribs and getting heartburn. Americans complain about heartburn all the time. And, what's involved in this diagnosis, and how should it be treated? Could heartburn be a sign of more serious problems?
Usually heartburn is one of the common problem in common American population.
Well, when you get to be 50, you have to have heartburn, right? You're not eating all the good
not
food.
Only 50, actually, the heartburn incidence is going up because now Americans are becoming much more obese, overweight. Obesity increases intra-abdominal pressure and increases the acid reflux. So people are getting more heartburn nowadays because of lifestyle and also the size and everything. Usually heartburn means acid coming to the esophagus in the wrong direction. Between the esophagus and the stomach, there's a valve called sphincter, and if it's very weak, it allows the acid going backwards. When the acid comes to the chest, they feel usually heartburn, but sometimes they feel kind of chest discomfort. And once a week or infrequent heartburn usually has no problem. You can take some Melanta, Malax, you feel good. But if anybody gets much more, 3 or 4 times a week, or if you have a heartburn or long duration, then we have to look inside the esophagus and make sure you have no damage.
So if it comes and goes away, in most cases, it's strictly
probably
heartburn.
infrequent one, we don't have to worry. On the other hand, if it becomes more frequent, we want to make sure there's no damage to the esophagus. If they have a damage, we have to give proper medicine like an Nexium, Prevacid to prevent or heal the damage. And more important thing is, esophageal cancer is the 4th common cancer. And one of the reason for esophageal cancer is frequent acid exposure to the esophagus, and they develop a condition called Barrett's mucosa because of irritation to the acid. If anybody have a Barrett's, they're prone to have a cancer. Especially white male people after the age of 50, they're prone to have high incidence of called esophageal cancer. So we do call endoscopy, or it's upper endoscopy. This is the opposite. We go through the mouth. Again, with the sedation, we go into the esophagus, stomach, and do want to make sure the esophagus is normal. And if they have a Barrett's, then we follow them closely once in a year, once in 2 years. If there's no Barrett's, then we do only when as needed.
Wendy, the preparation for that, do you get involved in that as well?
Well, the preparation for an upper endoscopy really is just that the patient shouldn't eat or drink anything after midnight. So, and the procedure itself is only taking about 5 minutes. So if they're scheduled, then we try to schedule them in the morning so that they're not fasting for too long. And after the procedure, they can eat again as soon as they wake up. Well, that's probably not a real good idea.
Actually, that's a good point, Mayor.
Something light.
We usually give them proper diet after we found out.
Well, that's my problem, Doc. I don't have the proper diet. So,
fatty food, fried food, sugary food, all increases the reflux. So we usually.
Oh, I know that.
Yeah, so we usually tell them to avoid those kind of food. Eat a proper diet, broiled chicken, fish, and 3 meals a day. Don't go to bed immediately after eating meal.
Right.
So those are and lose weight. That's more important.
You sound like my doctor.
Losing weight really helps minimize the reflex. So that's how we prevent.
Wendy, what's the magic camera pill that can take pictures inside the human body?
We've actually been doing capsule endoscopy for a couple of years now, right?
2 years.
Yeah, and it's we find that it is good in diagnosing problems of the small intestine because you can't really do an endoscope of the small intestine. We have used it on multiple patients and had fairly good results with it so far.
Yeah, it's a camera. See, currently we do upper endoscopy to see the stomach, and we do the colonoscopy to see the colon. Between the stomach and colon, there's a 30 feet small intestine. People with the diarrhea, people are bleeding, people are anemia, we want to know what's going on in the small bowel. Now we have a magic pill, small camera pill. You swallow that goes to the stomach, then start taking pictures. It takes 4 pictures every second. By the time it comes out, it took 50,000 pictures. So when the camera comes out, we don't have to worry, that goes in the John. But we put a receiver and we put in once they finish, once we take the receiver out, we put in the computer that shows as if we are going through the small bowel like a fantastic.
How long does that procedure take?
About 8 hours.
8 hours?
Oh, yeah.
8
They
hours
come in the morning,
to travel all the way through.
swallow the capsule, go home, then you can eat later on, come back at 4 p.m. or 5 p.m. and then we'll take the receiver out and then you go home.
And we download the images onto the computer.
The camera comes out by itself. And we put in the computer that shows as if we are going through. That's a remarkable test because that's one area we never been able to see with the magic camera. Now we can able to see the entire small bowel, so we're able to diagnose a lot of disease and we can able to help them out.
I want to thank you for taking the time to join us on the show this evening.
Thank you.
And I appreciate all of your efforts in preventing colon cancer and anything we can do to help. I know we do some public service announcements, but
Mayor, we want to thank you for
out there.
Mayor, we want to thank you, and just 2 points take home. One, if you're 50, please come for a colon checkup. Colon cancer is second common cancer, and if you have a heartburn for long duration, please come. Make sure you're not a risk for esophageal cancer. Those are 2 take home message.
Thank you.
Thank you, Mayor.
For Dr. Sami Muthusamy and Miss Wendy Bouchard, I'm Chris Bolwage. We'll see you next week on another edition of Our City.